Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
So just this announcement again that this is going to be your one more OSCE before your exams. Probably this OSCE will be the questions which I have not discussed so far. I think Feb 25, some questions, an OSCE I have not seen and not discussed. Anyways, I'll do that for the next coming Saturday and even Sunday maybe. Okay, have you seen this? These are the questions. I'll try to put the picture here only. I hope everyone has grabbed their pen and paper and has been scribbling down the answers now. Giving you time to please kindly answer these questions and share with me your answers in a sheet of paper. Just click the picture and send it on the chat group. And I'll be seeing your chats and I'll be replying. Okay, who is this? Very good. I mean, to be fast is also equally important, guys. Great. Archie, I'm proud of you, girl. I think by the kind of ectopic pregnancy case, everyone should have ratified by now the criteria for medical management and surgical management, isn't it? Very, very proud of all you girls. These girls are all my students and very good students actually. Currently with me in my LMR and doing very well. And they are the first ones to answer and I'm very, very proud of them. All of them actually. Very well done, Ankita. And I'm now going to be disclosing the answers. Let's discuss. You keep answering and you keep sharing, guys, okay? So the first one. The ultrasound diagnostic criteria. So can you see it's an interstitial pregnancy? It's said also, right? 32-year-old, G2P1, complains of 2 months amenorrhea, bleeding per vaginum, diagnosed with interstitial. Now, it's already told you it's interstitial ectopic pregnancy. Thank God for the first slide so that at least the diagnosis is there. The rest of the things we'll manage, right? Ultrasound and intraoperative findings findings were given above. Like this is the ultrasound finding and this is, see how it is. There's the uterus, the endometrial lining, and here somewhere is the interstitium, and there you can see a gestational sac. So, correctly so, empty uterine cavity with products of conception located laterally, probably in the interstitial part or the intramural part of the tube, surrounded by less than 5 millimeters of myometrium in all imaging planes, because now she is having an ectopic pregnancy in the interstitium. Over here, it can rupture anytime, it can torrentially bleed or might not bleed so much. You can have a hematoma formation, or it has an unpredictable course of action. You finally will have to go and excise it or use methotrexate depending upon the patient's symptoms. So empty uterine cavity, with empty uterine cavity, I'll put it here like this, okay? Empty uterine cavity, products of conception located in the interstitial part of the tube, surrounded, this is also equally important, surrounded by less than 5 millimeter myometrium. These will be the points. Yeah, these are going to be the points, width, and then surrounded by. So these are the 3 important diagnostic criteria of interstitial pregnancy. Come on. Criteria for medical management of ectopic pregnancy. You know, this is again RCOG guidelines. Nice. Okay. Everyone who's still answering, very good. I'll appreciate everybody who keeps answering anyways. Yeah. I was telling you that 4 criteria, 4 medical management criteria. Always remember hemodynamic stability has to be there. All right. Coming down to the picture of the beta HCG less than 5,000, but preferably less than 1,500. Okay. No fetal cardiac activity for sure. Patient should be asymptomatic mostly. Okay. Hemodynamic stability less than 1,500 or even less than 5,000 is fine. No fetal cardiac activity. Certainty that there has to be no intrauterine pregnancy for sure. Willingness to attend follow-up. No known sensitivity to methotrexate and should not have any symptoms. You know, if she's having pain, no significant pain. See, NICE recommends that methotrexate should be the first-line management for all women who are able to return for follow-up and who have no significant pain, unruptured ectopic pregnancy, serum between so-and-so, and no intrauterine pregnancy as well. What I'm trying to convey to you is that medical management has to be for these patients who are having no pain, no cardiac activity, no signs of rupture, hemodynamic stability, size less than 3.5. And preferably do beta HCG between 1,500, but even less than 5,000, we can give her a try. Very important slide. Very important slide. One of the most important slides, especially if your management is being talked about. What's the criteria of surgical management? Come on, the opposite will be the criteria. If she's not having hemodynamic stability, if she's having pain, she's having a size more than 3.5, maybe beta HCG above 5,000. Please mute yourself, guys. Mute yourself, everyone. Okay. All right. And if the cardiac activity is present, then you will not take her up for medical. So everything which is a contraindication for the medical management becomes indication for surgical management. So that means size more than 3.5, beta HCG more than 5,000, hemodynamic instability, cardiac activity present, ruptured ectopic pregnancy, mostly these. All right. Or the patient is not able to follow up. She's having methotrexate allergy or severe LFT deranged with methotrexate on methotrexate. You can abandon her, or failure of methotrexate regimen. These are all for criteria for surgical management. Okay, 2 approaches: laparotomy, laparoscopy. Clear? Now, as far as only cornual interstitial pregnancy is concerned, surgical approaches exactly for this particular thing will be laparoscopic or open cornual resection, or hysteroscopic resection under laparoscopic guidance. You can go hysteroscopically and also try it. But see, it's going to rupture abdominally only. Na? So finally, you'll have to go for either laparoscopic or laparotomy. That's the best way to go. Clear so far? Any further questions, anyone? Any further questions, anyone? Moving on to the next question. Just see these graphs and then I have a question for you. Okay, now see the questions, everyone. Okay, it's time to discuss now. First image, normal waveform. Do you see? This is normal waveform. Increased impedance to the flow. That means this is elevated S by D. This is what happens first, isn't it? How many times have I already spoken about this in the class? This is the way that this is the first thing to happen, the first change to happen. That means, first of all, it will be impedance and there'll be abnormally elevated systolic to diastolic. That means they're trying their best to let the flow through, but they are having difficulties, okay? So the pressure is increasing. Then comes the absent and diastolic flows. See, there are no diastolic flow, only systolic flows there. No diastolic flow. I'm sorry, this is the diastolic part. This is absent. Can you see that? And then comes the reverse flow, that means here. This is the one. This is the one. This is the one. So this over here, nothing is there. That is absent. absent end diastolic flow, and then it becomes reverse. So reverse end diastolic flows. Anyways, this is the first, second, third, fourth. Usually this is the course of events, okay? Because after this you start relying on the ductus, okay? That is the venous Dopplers. So ABCD is normal, increased impedance, absent, and reversed. Okay, everybody has written that, right? I have already seen. All those students who were there in my class on fetal growth restriction, we now follow the SWOG guidelines, and it's there in your FOXY, it's there everywhere. It's even there for RCOG. I have also included the RCOG guidelines. This is as per RCOG. Now, the SWOG actually is like, they say that for this female who's 30 weeks of gestation and now already having absent end diastolic flow, the next step, if there is absent end diastolic flow or reverse end diastolic flow, you will monitor 2 to 3 days unless delivery is indicated. But the next step is to do a ductus venosus Doppler. So you are going to monitor her every 2 to 3 days, and you will do that with the help of ductus venosus Doppler and with the help of computerized CTG, that is CCTG. And if you find that short-term variation less than 2.6, then it is worrisome for this gestational age. If it's less than 3, it's worrisome for this gestational age, and so on and so forth. This chart is of utmost importance. This chart has to be remembered and reproduced and should be remembered by everybody in the exams, especially if you get a case of fetal growth restriction, or even if you're around fetal growth restriction. Make sure in a case of preeclampsia also your Viva can go here. The moment you say that the fetal height, the fundal height was less than the weeks of gestation, you will be pulled into this dynamic whether you want it or not. 5 complications of fetal growth restriction: perinatal asphyxia, intraventricular hemorrhage, you know how it is, meconium aspiration, respiratory distress syndrome, hypothermia, glycemia, and necrotizing enterocolitis. Any questions so far, guys? Anybody with any questions? Okay. I'm here looking at your chat all the time. So just in case you're having any questions, please be open and please be bold about the questions. This, if you won't ask right now, then when will you ask? So the next question I'm starting, but I'm still welcome to any of your questions from the previous as well. Just don't ask me to flip the slides, okay? Moving on. It's a very easy question, okay? Very easy question. So people who've already, attended my fetal growth restriction case discussion, and by now I've already done thrice, so they know it by the back of their hand by now. What exactly would be the fate of this female if she has absent end diastolic flows, right? The next thing, what would you like to do? Pretty easy a question. So yeah, everyone, please make sure that you stick to this answer, especially from the guidelines. And which guidelines you're going to quote, that is also equally important. Okay, so I'm sorry I was there in the channel. Now I'll see my... Yeah, guys, come on. Answer this question. It's pretty easy.